This is where I practice over in East Side in Kirk. Oh, beautiful. Thank you, Doug. So this is where I practice, part of a 14-member orthopedic group. I'm the designated pain guy, and that's where we are. Is anybody doing stem cell, or are they exposed to that in your residency at all? So some are. It's good to hear. So this is Time Magazine. Time Magazine over the years has had like 4 covers on stem cells. So it's definitely in the public eye, right? So the public imagination has been exposed to the stem cell thing, going back to at least the early 90s. So another Time cover with Condoleezza Rice up in the right-hand corner. I think this is again from the 90s. This is from Wall Street Journal, going back all the way back to September 9th of this year. Title saying, "A hip or knee replacement without surgery, question mark." It's on the horizon. So this is, the popular media is definitely onto this, the whole stem cell thing, for better or for worse. So a little historical context. We've got the Alexander Massimov proposes the term stem cell way back when. I can't remember, it was like turn of the century. And then we've had things like prolotherapy, then orthobiologics. Arnold Kaplan at Case Western came out in 1991 with the term mesenchymal stem cell, which he later would kind of had some, I guess, regrets. William Hazeltine with regenerative medicine terms. Is that I'm having trouble reading that one, 1990, whatever that was. Then Arnold Kaplan comes out again in 2017, says, "I wish I would have called them medicinal signaling cells instead of mesenchymal stem cells." Another person, Philippe Ernegoul in Paris, France, outside of Paris, France, actually, orthopedic surgeon who's been doing mesenchymal stem cell injections with bone marrow-derived stem cells. Kind of a pioneer doing this since like late 80s, early 90s for various things. Then we had this proliferation of stem cell clinics. I don't know where you guys are from, but certainly in the Seattle area, we had these stem cell clinics sprouting up everywhere. A lot of them were chiropractors who were hiring nurse practitioners to do the actual injections and using off-the-shelf umbilical products. So that was kind of a problem. Oh, here's Arnold Kaplan's article coming out in 2017, says, change the name to medicinal signaling cells. Here's the literature just kind of exploding, starting about in the early 2000s. This is worldwide. You see that Europe, East Asia, North America. Just a number of publications just kind of taken off there about that time. This is obviously not restricted to the U.S., but this is happening worldwide, just a number of publications regarding stem cell research. I'm going to continue to use the word stem cell, even though I do have some misgivings about that. I think cell-based therapy is probably a better choice of words, but we're stuck with this because when my patients come in and talk about something for their knee, they're going to say stem cell, and so that's the common language we're going to use for them. All these healthcare systems in Mayo Clinic, Cleveland Clinic, Emory, Yale, University of Miami, and our own Swedish hospital here in Seattle have, on their website at least, tipped the hat to regenerative medicine, including stem cell therapy. And we're in fact finding uses all over the body. And I started using it about 7 years ago when I was with another clinic, and I got to admit, I was fairly skeptical about the whole stem cell thing. But then my very first patient turned out to be a pathologist who came in to have both knees injected with autologous mesenchymal stem cells. And I'm like, okay, here we go. And the way we did it there, she came back 6 weeks for her PRP booster, and I was like, okay, what's going on here? Went into the room, and she's like smiling ear to ear. She was totally happy with the progress she'd made in literally 6 weeks. And I'm like, okay, well, that's interesting. Maybe I'll have to adjust my attitude a little bit about this whole thing. So that was like 7, 8 years ago since kind of embraced it to a certain degree in my own practice, for sure. So a little bit of FDA regulatory context. There's this code, Federal Regulations, what is it, part, blah, blah, blah. Basically, they want minimal manipulation. It has to go back in the body within 24, anything you take out of the body has to go back in within 24 hours. Apparently, after that, it becomes a pharmaceutical. So I don't quite understand that logic, but that's, hey, that's the FDA, right? So interesting stuff. You know, we have this history of some bad actors getting into this. This is a fascinating podcast. I don't know if you guys ever watched this or listened to this Bad Batch, where this guy was working with chiropractic clinics across the country and taking tainted, we'll call them birth products, and just a very hard sell and taking lots of money out of people with a very dangerous situation and putting people at risk. Anyway, if you're interested. Then this consensus statement came out from a panel, like 2-3 years ago now, about talking about some of these scams and saying basically most of this stuff shouldn't be called stem cells for whatever reason. So intradiscal biologic treatments, now we're getting to what we're talking about today. There's a history of using different things, fibrin adhesive, BMP, growth differentiation factor, which I don't even know what that is, alpha-2 macroglobulin, PRP, which has some fairly significant high-level studies for intradiscal use, certainly the autologous MSCs, and then cellular therapy, which all include things like viable allograft therapies, which I will talk a little bit later. So this is kind of a big article here by Wu, where they took over 1,300 articles, of which 6 were eligible for this review, basically a meta-analysis that met criteria, and said, you know, yeah, this really worked for intradiscal therapy. So this is, next few slides, including that last one, I'm indebted to my good friend Doug Beal sitting over here, which I've totally plagiarized his slides, and not the first time, by the way. This guy's great. This guy's like a resource for me. I'm giving a talk. I said, email him like the day before. Hey, Doug, I'm giving a talk to some ER docs about kyphoplasty. Can you give me a little whatever? And he's so good and so diligent, responding so graciously on those kind of short time demands. So anyway, it talks about how this changes over time. You know, dealing with discogenic pain versus facetogenic pain, depending on what. So younger age groups, that discogenic pain from internal disruption, and then moving on. Just moves on, and then you get to the older age group where there's, you know, all causes. But most of my patients really are kind of past the discogenic. I'm seeing a lot of patients, and it just happens in my practice, that are probably a little on the older side, 65 or plus, just the way it's kind of turned out. So a lot of those folks are primarily the discogenic pain is on the wane, and the facetogenic pain is definitely on the rise. So we treat a lot of facetogenic pain with stem cell. We try the, RFAs, facet injections, medial branch blocks, RFAs, but I will tell you that my experience with stem cell with facet pain is fairly, the success rate is fairly remarkable in those folks. Now, this is an area that I have very little knowledge. Again, Doug Beal has a lot more knowledge on these studies of these allogenic products, Mesoblast and Viadisc with Vivex Biomedical. And these have been both studied very well. These are commercial products that are basically cellular constructs to inject into the disc to help with rejuvenation of the basically the architecture of the intervertebral disc, including the nucleus pulposus and the surrounding elements. A bunch of ongoing trials here listed. completed trials. I think the VAST trial is the one that for Vivex, I believe. Doug, is that correct?
Yes.
And Mesoblast is already completed. That's a completed trial too. And basically, they're showing fairly significant success with improved, markedly improved VAS scores and improved ODIs, and fairly limited in the way of any kind of downside. So here's one of Doug's slides comparing rexlemestrocel. Viadisc, obviously easy to say. Rexlemestrocel, I don't know what it is, but those two products there, again, showing significant improvement in the VAS scores head-to-head. So here's a random subject showing 6-month follow-up. Basically, the VAS score going from 58 to 0, and it might not come out that well, but obviously the T2 signal improving significantly from over the 6 months. So similar thing. This one is 12-month follow-up with, you can see the T2s definitely improving in that intervertebral disc there. So here's the fascinating question for me is, when do we start this, right? I mean, because mostly patients come into my clinic, probably most clinics, for pain. Is pain the best way is that the best indicator? When do we start doing these regenerative treatments? We know that basically it's an inexorable decline in function, whether it's an intervertebral disc or a knee joint or a shoulder, whatever. So that's, to me, it's an interesting question about when do we tell people, hey, you know what, we got to think about this. Intervening with stem cell or regenerative medicine of some sort. So this is like my patients. This patient's got, multiple issues: degenerative disc disease, spinal stenosis, especially the L4-5, facet arthropathy. The multifidus muscles look not enough meat. They're too marbleization, fatty infiltrates. So I would say that's more consistent with my pain population as opposed to a patient with a pristine single disc that is a pain generator. So our setup is pretty straightforward. We have a procedure room. We have I do primarily bone marrow autologous stem cells, fairly straightforward. There's my MA Justin putting in there. We have a couple different machines. This one's Zimmer Biomet system. Oops. Oh, that's terrible. Sorry. I apologize. That didn't come out well at all. There's a patient, so this 70-year-old gentleman, I'll just have to describe it, but he's got 2-level discs are well preserved. Disc spaces are well preserved. Do you see that at all? I apologize. But anyway, he's got some annular tears. He came in with annular tears, supposedly L4-5, repeated the MRI. He actually had tears at 4-5 and 5-1. Had some, let's see the other slide. Not so good either. But he had some facet arthropathy. We kind of did some injections. That really wasn't where the money was, so to speak. So it was clearly discogenic pain that we proved on discogram. He was a local radio personality guy, and we did end up, after provocative discograms, end up doing intradiscal stem cell. And he had, within, I would say, probably less than 6 weeks, had started having dramatic improvement. This is a man who couldn't even put his shoes on without a lot of pain. And, couldn't sit for very long. Clearly discogenic pain that was impacting his life. And to this day, this was in 2018, still today is doing great. I keep in touch with him. So just one example of, this is out of Pain Physician, just responsible guidelines for using biologics in general for low back pain. I suggest you guys maybe look through this. So going forward, we, a lot of questions. This thing called exosomes. which is basically cellular packets of information going from, stem cells or whatever, containing proteins and mRNA, the cells sending out these little work orders to the surrounding. It's like a paracrine effect, if you're familiar with that term, paracrine, influencing neighboring cells. So this area is rife with what I call proprietary tendencies. In fact, there's a clinic outside of Denver, Regenic, Dr. Steve Centeno. I think he's a really brilliant guy. He's published a lot of stuff, very much forward-thinking. But in his opinion, he's the only one that does stem cells right. Everybody else is bogus. So it's that proprietary tendency that everybody has their own recipe so there's not enough standardization, I think. That's a big problem. And you look at a lot of these studies, everybody's got their own little cookbook. So that tends to be a problem going forward. So we need to have some standardization of what's going on when we do research in particular. Third-party reimbursement. So patients ask me, well, because it's currently stem cell not covered by insurance, except in very rare circumstances. So I get this question all the time, at least once or twice a week. When do you think, doctor, stem cells can be covered by insurance? And I'm like, not in my lifetime, most likely. There's just too many issues, political and otherwise, I don't see that happening anytime soon. Regulatory concerns, what's the FDA going to do? Are they going to kind of relax things where we can actually culture or expand cell? If you're taking cells out of your body, who do they belong to? Do they belong to the FDA or do they belong to you? My opinion is they belong to you. I should be able to expand them and re-inject them in whatever. I think that's pretty clear cut. So the FDA people would beg otherwise. So last point, longitudinal care. I very much believe in following these patients over time. It's not a one and done, like, okay, we're going to do stem cell and you're going to be great, see you later. No, we follow these patients and we tell them, hey, we want to see you at least, we see you in the first year, 3, 6, 9, 12 months. And going forward after that, we want to see you at least once a year. And the reason is, I want to know myself how well you're doing. And the fact is, we don't know. I have some patients who I've done stem cell injections on, for example, their shoulder, and they're doing great after 6 years. And others who have required a lot more. So we'll offer them like PRP boosters or a repeat stem cell. And so, this is cash out of their pocket right now. So I just tell patients, look, if we repeat it, I'll charge you half price. Because, these are hard-earned dollars that people are spending on this stuff. So I'm not interested in kind of maximizing the revenue. I'm interested in seeing these patients do well. And it is exciting. It's an exciting area and seeing how many of these folks do well. Overall, I would say, just in general, large joints, shoulders, and we follow these patients with the questions, basically, patient global impression of change, and would they recommend it to other people? Shoulders, the success rate, probably around 80%, which is kind of nice, because shoulder surgery is a pain in the ass. I'll just be honest. Knees for the second place, I'm talking about just large joints, probably 70%, 70, 75. Hips, interestingly, probably 60, 65%. The good news there is a hip replacement, anterior approach, that's pretty good. I've had people come in to my office looking for stem cell for the hip, and I take an x-ray and I don't just save your money, just go get a hip replacement. And I've had people get upset with me, but I just I'm not, this is not, I got to tell you what's best, really, in my own opinion. So, this is an interesting article out of Temple University talking about this protein. What is it? I can't even read it here. LIN28A. So they found that, the only reason I found this, my daughter's a medical student at Temple, so she sent me this. They inject this protein into myocardial cells, And this protein is only found in developmental cardiac muscle, not found in adult cells. So when they do stem cell treatment for things like MIs, they found that the survival rate, because it's an anoxic environment that they're injecting these cells into, and by just injecting this protein, though the viability of those stem cells are dramatically improved, apparently. So just a reminder to maybe we got to look outside our own little silos, what's going on with regenerative medicine and other disciplines. So that's kind of why I stuck that slide in there. Anyway, that's a shameless plug for my favorite organization called Climb for Captives. We raise money for victims of human trafficking through a group called Rescue Freedom Organization, rescuefreedom.org. They work literally all over the world. So great organization, highly rated as a enterprise doing good things. So that's pretty much it. Questions?
I have one question. How safe are they? Have you encountered any complications?
Yes, that's a great question. And I maybe asked my good friend and colleague Doug Beal. So once in a while, you get these. So wound healing has 3 phases. Anybody know what those phases are in general? An inflammatory phase, a proliferative phase, and a remodeling phase. So in the stem cell, you kind of reproduce that in some sense. So and some people get this very profound inflammatory phase that is just off the charts. In fact, I've had a patient who I did intradiscal stem cell treatment, immediately got a florid discitis. I mean, boom, like the next day, and had to admit him to the hospital. We get the hospital's involved. Infectious disease, and of course they want to put them on, but they say, well, it's obviously an infection. And I'm like, wait, whoa. I don't think this is an infection. There's no way. There's no way that infection happens this fast. I'm trying to explain to them that, hey, we see this once in a while. This is just an inflammatory reaction. It's an outlier, but it happens. But what's an infectious disease person going to do? They're not going to sleep until that person's on IV antibiotics, right? So, and I know Doug Beal's dealt with the same situation, and I've had a few folks. I had one guy who lives in Gig Harbor who we did stem cell for his knee, and he had this profound reaction. Inflammatory response. Knee swells up like a basketball. I'm draining his knee I must have drained his knee like 4 times. And then at 9 months, turns the corner, he's happy as a clam. Comes back and gets his hip done. That's how happy this guy was. But during that time, it's kind of rough. You're just holding their hand and you're praying that, eventually those patients. So this is the complication rate. If you get in this area, I guarantee you'll see some of this hyperinflammatory response. I don't know what else to call it, but I think that's what it is. And, knock on wood, most of those patients that I've seen that have had that have done okay. But it's nerve-wracking to see that because it looks like an infected knee. I mean, a guy blown up, all the symptoms of it. Except, so the patient that put in the hospital, white count, normal. Everything normal. And I was telling the infectious disease doc, there's the white cell count's normal. All the inflammatory markers normal. One of them, the inflammatory, I can't remember, CRP might have been elevated, but it's like it's not an infection. Okay, anyway, you got to be prepared to deal with that possibility in this situation.
Because Dr. Nelson, would you agree, like any PRP, and Doug, I'm sure you know as well, any PRP type of injection, you're going to have significant inflammation occurring, and that's expected. And
totally.
For these sports medicine clinics that are constantly putting PRP in, they tell their patients, you're going to get an inflammatory response. You're going to hate me for a little while, right. And it's going to get a little better and better and better. Yeah. Doug, what do you think?
So we've written a whole subchapter in a book about this. This is just a post-injection inflammatory response. And it happens with anything you put in there. It happens with fibrin glue. Tisseel, Discseal, OP1, Vivex, Mesoblast. I've seen it in everything, and it's exactly right. There's only like a handful of people in the world that know that this exists, and you're one of them, Dan.
Right.
Because it looks like a discitis. It isn't. It's got erosion of the end plates. Looks like a discitis. Everything. But SED rate is normal to maybe a little bit elevated. C-reactive protein, normal. No fever. Back pain, white counts normal. Mm-hmm. So this is just, Arnold Kaplan says that these are immunoprivileged cells. But later, he also changed his nomenclature on this, saying that these are immunoevasive cells. And sometimes your cells can't really evade the immune system very well. They get captured, and this happens. Right. So, and this is just part of it. The other component, which I agreed with almost everything you said in there, which is really unusual. But this is not that much of a contrarian. But the fact that this stuff works, and it works exceedingly well. The greatest challenge we have is not the outcome, because out of the Mesoblast and Vivex, this is 622 patients, triple-arm randomized controlled trial, level 1 data, and it reduces pain and improves function up to 60 to 70%. This is great. The real challenge is regulatory, and I always feel like, now May 31st of this year, 2021, the FDA kind of is cracking down on people that are using stem cells to any significant degree, especially advertising it, things like this. And so that creates a problem. There's something that works extremely well for this group, how to incorporate it into their practice. I mean, that would be my question. What advice, Dan, would you have to them? Because this is kind of hard, because this is something that we've really relegated to doing this only on the clinical trial. Before that, we had a vigorous regenerative medicine program. But frankly, I'm afraid of the FDA. And there's no telling, and because we do so much work in this area, you either have to treat it as a 351 or approach a biologic licensing application or a BLA, or approach it as a 361, minimally manipulated homologous use. And so they've really become a lot more critical about this lately. So,
right.
I mean, any tips or tricks?
No, not really. I mean, I think using autologous products goes right back in. I think, at least in my mind, that's maybe more palatable to the FDA. I don't know, but I gotta tell you, I feel like the sword of Damocles hanging over my head every day. I don't know when that's going to drop. So it's interesting. The state of Texas, I don't know if you're familiar with them, but they've told the FDA, hey, you know what? Texans kind of they own their own body parts, and so they kind of pushed back the FDA and said, hey, we're doing what's good for Texans. But then apparently they formed a committee and of course committees always, the people that go to committees or serve on committees have a certain tendency to do things a certain way. But, I just got to believe it's ultimately, I don't know what the FDA's, I could go on a soapbox here. FDA and the pharmaceutical industry, I mean, there's so much of this going on, right? You rise up in the FDA, you take a job over here. It's just I'm not, I just think there's some issues there that I'd love to see some resolution. To me, it's like a no-brainer. This is coming out of your body. It kind of belongs to you. It's common sense. But I realize that there's a lot of politics in play here. So, all right. Hey, thank you very much. I appreciate it.
Thanks, Dan.